Thank you very much for the opportunity to share with you some of our planning for our hospital system mobilization for coronavirus. I'm Will Barsoom. I'm the CEO and president of Cleveland Clinic, Florida. I'm also a practicing orthopedic surgeon that does hip and knee replacement. One of the first things that we did when we started our planning was we established a clear incident command. We've actually activated our incident command several weeks ago. These were set up at each of our individual hospitals, and then they all fed into a joint management task force that led all of our COVID-19 planning for across the organization. Within that COVID planning joint task force, we had several verticals, and I think it's worthy of discussion around what those verticals represent. The first is a regional personal protective equipment vertical. This group would look very commonly and very frequently at the PPE that we had available, things like N95 masks, surgical masks, gloves, gowns, and this type of thing. Following both the World Health Organization and the CDC, Center for Disease Control, we tried to establish all of our policies so that they would align with them, but at the same time take into account the impending shortages that we were seeing happening both in other parts of the country and around the world. This group has been very successful in bringing ideas and a very logical thought process to how we would roll out our PPE. The second is local workforce planning, and you'll hear more about that in a few minutes. This is a group that really looked at our people and how to ensure that as people were finding that they had more time since our elective surgical procedures were dropping and our outpatient care was dropping, that they could be assigned to other purposes. This was not only for nurses and secretaries and finance people, it was also for physicians and advanced practice providers. The third group is a local operations logistics group. This was the group that was really charged with making sure that we had enough hospital stretchers, that we had enough oxygen for increased oxygen requirements with the increased number of ventilators that we were expecting, making sure that we had enough ventilators and that our space was all appropriately set up. Finally, a regional caregiver wellness group that was really charged with ensuring that our most important group, which was our caregivers, was well taken care of throughout this process. All of this wrapped into the Joint Task Force for COVID-19. In addition, we set up a disaster modeling contingency planning group that utilized predictive models to try to get a good sense of what kind of surge we should expect. And we divided this up into space, equipment, and people, making sure we had enough space, making sure we had the appropriate equipment, and the correct number of people to manage to that surge. And again, we'll talk about this in more detail in just a moment. One of the first things that we did as we started preparing ourselves for the COVID-19 crisis was to decrease access to our hospitals. This went into place very quickly. Part of the things that we put into place were decreasing our outpatient visitors to almost none unless a patient required assistance. The second was offering much more enhanced telemedicine opportunities so that our patients had access to their caregivers, but at the same time, we were able to decrease the density of individuals in our sites, and that was extraordinarily helpful. Another area was setting up our entire campus with stop signs on all the windows, trying to get patients who were symptomatic to come to outdoor screening and testing areas that were held in tents to minimize the risk of introducing any significant viral load into our hospital sites. We limited our patients to having only one visitor, and even that was limited to only folks that required special assistance or for end-of-life care. By putting these restrictions in place, we were able to significantly decrease the density of the patients in our facilities, as well as increasing the access. Finally, we shifted many of our caregivers to being able to work from home, including our patient-facing providers who started adopting telehealth visits at a much higher rate. We went from offering only about 100 telehealth visits a day to now being well over 1,000 a day through these new modalities. The second major step was canceling elective procedures, and we followed both the CMS, Center for Medicare and Medicaid services guidelines, as well as our state guidelines around what was considered elective, urgent, semi-urgent, and emergent. We put a task force in place that would review all of the procedures that were potentially going to be done and make sure that we were following appropriate procedures. High-risk procedures such as colonoscopies and bronchoscopies were for the most part delayed unless they were emergent cases with clear, honest, transparent discussions with the patient as to why they were being delayed. In addition, things like elective total hip and total knee replacement were also for the most part delayed unless they absolutely could not be for the sake of the patient. One of the big areas that we spent a lot of time focusing on was surge planning. And the reason surge planning became so important was so much of the predictive modeling that was in place was predicting massive surges in the need for inpatient beds. We've obviously seen that in many places around the world, including in China, in Italy, and certainly in parts of Europe. By making sure that our surge planning was in place, we felt that we would be best prepared for any impending increases in our patient populations. To give you a sense of where we started, across the Southeast Florida region, we'll look at 5 hospitals. These 5 hospitals made up a total of about 1,005 beds. By walking our spaces, looking at our equipment, cross-training our clinicians, including groups like myself, orthopedic surgeons, to be able to manage ventilators if necessary under the supervision of a critical care doctor, we were able to easily surge within our own campuses to 2,016 beds. Of note, we went from 144 critical care beds to a factor of 3, 466 critical care beds. Now, again, when you think about managing 466 critical care beds, and our numbers show that about 60% of our critical care patients require artificial mechanical ventilation, you also have to be planning for incredible oxygen needs. So all of these logistical steps were put in place to ensure that we had enough oxygen, we had the appropriate med gases to be able to take care of all of these patients. In addition to training our doctors, we trained many med-surg nurses in being able to step up into critical care nursing under the supervision of more experienced critical care nurses. Not only through our own facilities could we surge up to these 2,016 beds, but in addition, we've identified outside places that are within the walls of our institutions, but are potentially unfinished spaces. And we could take those spaces and use things like cots and short-term bed utilization to take care of patients that would require things like nasal cannula or low-flow oxygen, but required nursing assistance. One of the major areas that we've looked at, especially when it comes to reducing the utilization of personal protective equipment, is the cohorting of patients. So as we've identified the first sites that we would utilize for COVID positive areas, we decided that as each site came to 70% capacity, we would then activate the next site. So in this side, you can see that our first patients were placed in the medical intensive care unit. We had a live dashboard that would show us every day where these patients were, and as each unit hit 70% capacity, we would then activate the next unit. By doing this, with the cohorted patients, we could convert the entire unit into a COVID positive unit where personal protective equipment could be utilized to take care of more than one patient. In other words, our caregivers would dress one time for the day, would then cover a N95 mask, for example, with a surgical mask, and then would throw away the surgical mask if it were soiled, keeping the N95 mask clean. This has allowed us to save a tremendous amount of personal protective equipment. Another area here is the reutilization and recycling of personal protective equipment, with N95 masks specifically being identified as an area that was high risk for a shortage, where we are now utilizing vaporized hydrogen peroxide to recycle these masks. We're doing it as much as we can in ensuring that each caregiver gets their own mask back, but those that we weren't sure we could do that with, we have saved and we are recycling and keeping set aside to use later if we run out of the individual recycled masks. The staffing plans and cross-training have been absolutely key to ensuring that our caregivers are ready for a surge. We, again, keep a dashboard going at all times that includes physicians, residents, nurses, independent practitioners, as well as advanced practice practitioners. We've also asked many of our caregivers who have seen their workload decrease to do things that they perhaps never thought they would be doing. Things such as packing lunches for quarantine caregivers that are at home, helping these caregivers with activities of daily living like shopping and bringing the things to their home, but at the same time ensuring that they are kept safe. This idea of really managing our staff across the organization has been extraordinarily helpful in terms of meeting all of our needs, not only in terms of the direct care of patients, but really also in terms of keeping our caregivers completely occupied and feeling a sense of being able to help others that are in need, even though they haven't been doing what their daily job was in the past. Finally, I want to focus a bit on caregiver wellness. The whole idea around caregiver wellness has really been to ensure that our most important folks in the organization, our caregivers, are well taken care of. And through our caregiver wellness efforts, we have identified several areas. The first is establishing our caregiver hardship fund. This caregiver hardship fund is available to all caregivers as well as first responders who might have any issue meeting their mortgage needs, their rent needs, buying food if one of their loved ones was laid off of work. At the Cleveland Clinic, we've made a commitment to keep everybody whole from a salary perspective. That's wonderful, but that doesn't necessarily mean that their partner may also be in the same position. So this hardship fund has come into use frequently recently for caregivers that are seeing a difficult time. The second is access to child care referral services. This has become especially important since the schools have closed and more children are at home and need help. We've created a caregiver survival guide, which is available on our intranet so that all of our caregivers have access to this. Relaxation stations are now up and running in all of our hospitals, where hands-free massages through the use of massage tools can be given to all caregivers when they just need to relax for a little bit. We've put into place a support housing program for our caregivers who might be quarantined or might live with elderly parents who are at high risk at home. In this scenario, we've actually established relationships with our local hotels who have seen very decreased utilization recently, and we're able to quarantine our own caregivers at those sites. We've arranged discounts for takeout food and delivery food from many restaurants around our communities, and this has been extremely gratifying for our caregivers. Hero fuel stations for patients and caregivers who are seeing many patients and not getting much of a break. They can step outside and fuel up to be able to get back to work and take care of their patients. We've established a 24-hour caregiver hotline where we have 24-hour nurses available to answer any questions around COVID-19 and occupational health questions. In addition, this hotline is also staffed from 7 a.m. to 7 p.m. 5 days a week by our human resources partners. Executive rounding has been extremely important with significant visibility of our executive team around the organization. Finally, we've put crisis counseling into place, which is available for all caregivers, as we've seen around the world that depression and anxiety have become very real problems for caregivers who are dealing with this challenging disease. So we want to be sure that our caregivers do have access to crisis counseling whenever they need it. I hope that this summary has been helpful in preparing you and giving you a sense for what we've put into place to ensure that we are prepared for our COVID-19 surge. If there are any questions, I'll look forward to answering them later. Thank you.